All right. Good afternoon, everyone, and welcome. Yes, welcome, welcome. Thank you for joining us today on the special webinar, "The Future of Evidence-Based Healthcare Facility Design and Construction." We are very thrilled to have such a diverse group with us today. We have alumni, current students, healthcare professionals, and industry partners. Whether you're tuning in with a background in administration, architecture, clinical operations, or just beginning to explore this area, today's session is designed to offer valuable insights into one of the most critical and rapidly evolving aspects of healthcare delivery: the spaces we build and how we build them. As healthcare continues to shift towards outpatient care, virtual platforms, and teams based delivery, our facilities must adapt in tandem. From budget constraints to technological integrations to patient centered design, these decisions carry long term impacts on care quality, efficiency, and the day to day experience for patients and staff. We're very excited today to feature two incredible speakers who bring deep expertise and complementary perspectives to the conversation. Greg Johnson is a seasoned healthcare architect with over 35 years of experience leading major hospital, clinic, and specialty care projects. We're now proud to have Greg joining us as our newest adjunct professor here at Clear Lake. He will begin actually teaching in 2026 and bringing real world design thinking into the classroom. Lee Holmes is one of our graduates. He graduated in 1997 with his joint MHA MBA. He's a distinguished leader in healthcare administration, accomplished entrepreneur, and a U.S. Air Force veteran. His leadership spans both private and public sector healthcare systems, offering a unique lens on operations, leadership, and innovation. Together, Greg and Lee will have a conversation to explore how healthcare architects and administrators can work together more effectively, bridging the gap between design vision and operational reality to ultimately enhance patient care safety and system efficiency. Just as a quick logistics heads up, if you have any questions, please do type them in our Q&A. I will compile them throughout the length of the webinar, and then towards the end, I will moderate those questions with our speakers. Also, this webinar will be available. A recording of this webinar will be available, which we will email you a link to it with the email that you provided upon registration. So, without further ado, let's move forward to our conversation today from Greg Johnson and Lee Holmes. Greg and Lee.
All right. Thank you, everybody. It's great to be here. As Jordan just noted, my name is Greg Johnson. I'm an architect. I've been doing healthcare architecture for over 30 years. And so I'm excited to be here today. Dr. Holmes, would you like to introduce yourself and tell us a little bit about your background?
Absolutely. Good afternoon, everybody. Lee Holmes, as Dr. Mitchell said, I'm a graduate of the dual MHA MBA program from University of Houston, Clear Lake, back when it was taught at Clear Lake. And so very brief overview. I'm a Texas A&M undergrad, did 8 years on active duty flying B-52s in the Air Force, separated from active duty, got my graduate degree from U of H, and then have worked for about the last 35 years in a combination of generally upwardly progressing roles across both public and private space. University of Houston, Medical Branch Galveston, UT Houston, Baylor Scott and White Health, and 3 private practice groups. Currently own and operate my own company, Diasante Health, that runs in the virtual healthcare space. And one of the things that I bring to this is kind of the practical approach. All of my roles were administrator or COO or CEO. None of my roles included the job description, build hospitals or build clinics. But when you're in a leadership role in healthcare, you frequently, if not always, throughout your career will find yourself in a position where the facility that you're in either has to be substantially renovated or replaced due to a number of factors that we'll talk about during the presentation today. Generally, it's just growth and you need more space, but sometimes it can be regulatory requirements. We had to replace a hospital because of asbestos requirements. So just one example. So clinically, I'm or by trade, I've got the fellowship in healthcare administration from ACHE, so I'm an FACHE, also a fellow in ACMPE on the medical practice executive side. So happy to talk to you all about a number of things, but today we're going to be a subject matter expert on the administrator's role in building, programming, and planning around facilities design and construction. So I'll let Greg kind of lead the topics from a architect and design standpoint, and then I'm going to jump in and accompany that with the administrator perspective.
Awesome. Thank you, Lee. I'll share my screen here in a moment. Just to elaborate, I also went to Texas A&M, and I've been doing healthcare here in the Houston market as well as around the state and the United States in a variety of capacities. And like Lee mentioned, new buildings and renovations. A lot of people don't realize that a lot of the activity that goes on inside of hospitals. Obviously, new buildings and things like that get a lot of attention, deservedly so. But there's always activity going on and interaction with design teams and administrators. So with that, I'm going to share an outline of what we're going to talk through today. So give me one moment here. Hopefully everybody can see that screen. Awesome. Okay, so we've done introductions. We're going to talk about the goals a little bit more. And then we came up with a few topics we felt like would be good for Lee and I to talk through, again, at a very high level. Any of these topics and probably a lot more could lead us into a lot of deeper discussions that we probably won't have time for today, but recognize we're going to talk about scoping projects. That's important. How do you manage projects? And then trends within the healthcare industry. We've listed a few. There may be others that folks come up with. And then a little bit of lessons learned at the end. Lessons learned hopefully will probably permeate all of these, but wanted to kind of give everyone an outline of what we're doing. We've talked about ourselves here already. So, and the goal today, and Lee kind of hit on this, is really looking at high-level considerations for successfully delivering healthcare construction projects. As a future administrator, this is something that, as Lee noted, you don't always get schooling on. You sort of learn on the fly sometimes, and hopefully that's changing. And this seminar is an example of that, and the course that I'm going to be starting to teach next year will also begin to focus on design and construction. So with that, I guess, Lee, if you want to kick this off talking about the scope of a project and what are the key issues, and then I'll follow up with some thoughts.
Absolutely. So, this is going to depend largely on what is the requirement. So in a world in which we want to be successful, successful outcomes in design and construction frequently aren't known until the project is complete, or sometimes several years after the project is complete, when problems start cropping up. And the way to avoid that is to make sure that you have the right requirements spelled out in advance. And the key to that is having the right people on the team that are defining the requirements. So as they frequently say, what you see and what you believe depends largely on where you stand. So if you're the administrator, you're going to see probably the financial side, but a hospital or a clinic or an ambulatory surgery center, these are nothing but buildings, spaces in which practitioners provide patient care. So you absolutely must have practitioners, clinical practitioners on your team, and they need to be integral parts of how you define your requirements. So sitting down and talking about what are the required needs, what's driving this project? Is it growth? Is it expansion? Is it movement into a new geographic market and you're going to take over an existing facility, or you're going to build a from scratch facility, what we call a greenfield project from the ground up? Each one of those different environments is going to require a different approach to how you scope the project. So A, understanding the nature of the environment, B, having the right people on the team, and C, much like you would do a strategic approach to doing a strategic plan where you would do a SWOT analysis, you would sit down and bring in all of the people that you would use for a SWOT analysis to define what are you trying or attempting to achieve with this project. So are you trying to grow from 500 patients a day to 1,000 patients a day? What is the anticipated length of time that this facility is going to need to survive or serve your patients during that time frame? What is going to be the patient population daily, weekly that you're going to need to serve? You need to make sure that you have both primary care doctors and specialists involved. The specialists are going to want to have a lot more involvement in procedural space design, operating rooms, pre-op, post-op, ER, and then the primary care docs, of course, are going to be predominantly focused on regular ambulatory clinic design, labs, pharmacy, and then you need to think very purposefully about process in addition to scope. So based on the type of environment and the type of patients that you are serving, what is the flow that's going to be required? Frequently, we build our buildings around this is how we've always built buildings approach, with little regard to workflow and clinical flow of patients. And if you're going to move patients effectively and efficiently from a sign-in area through a check-in, through the initial clinical assessment, through wherever the practitioner's delivering care, through a follow-up area, you need to map that entire flow out and make sure that all of the areas that are involved in that, whether it's bed management, if it's an inpatient area, or the clinic administrator in an outpatient environment, are involved in analyzing what is the most effective, efficient way to get patients from sign-in through the process that we're designing. So that's bullet one. Setting a budget is fairly self-explanatory. We don't have the ability in today's setting to get into a great level of detail, but simply stated, you need to know what you can afford and you need to work your requirements within your budget. It is critical to understand in the complex environments that we work in today, are there any financial limitations of your budgetary sources? There are budgets that have different flavors of funding, and some of those are restricted for certain uses. I have a very close friend who, unfortunately, found himself crossways with the state comptroller's office because they used budgeted funds to build a parking lot that were restricted and had been purposefully allocated for the hospital. And they were behind on the budget and the construction for the parking garage. And so they shifted some funds. The CFO shifted some funds from the hospital over to the parking garage. Long story short, all the CFO, the CEO, and the COO all found themselves unemployed. So you need to understand your budgetary constraints and work within your budget. But definitely either a CFO or a comptroller need to be part of your conversations in scoping the project and setting a budget around the project. And finally, communicating out the scope. We frequently find that communication in these projects goes one way instead of two ways. And that's, I will just say, a recipe for disaster. You need to be communicating early and often the results of the scoping and the process as it moves forward. But the best way to have a successful outcome is to clearly and accurately define your scope, and then make sure that you have CEO level buy-in to that scope, so that at the highest levels, and that includes clinical, whoever your lead clinician is, whether that's a chief medical officer or a department administrator, a department medical director, you need to make sure that the physician leadership is also supporting this, so that once the project begins, we don't have what we call scope creep, and that can quickly spiral out of control. I was telling Greg about a project where we ended up we were about 6 months into the construction of a new hospital, and we were on track to be 2 years behind schedule at completion and 400% over budget. And the CEO stopped construction, tore the hospital construction down to the ground, and we were into second story. The foundation had been poured, and we were up to second story iron construction of the beams. And we tore it down to dirt and started from scratch. So that's a level of extremism that hopefully none of y'all will ever see. But that all happened because the leader failed to stick to the initial scope and allowed people to add things that were well outside the initial scope. All right, I'll stop talking. I'll let Greg throw in his part about how he manages these problems from the design and project manager standpoint.
All right, thank you, Lee. Now, that was very well said. One of the responsibilities of a design professional is to help you as an administrator define the size and budget of a project often. As an administrator, I observe a lot where you will get a lot of requests, and many of them are going to be contradictory, or you're going to have a lot of opinions coming to you, and a lot of wants and a lot of needs, like Lee said. So part of what we can do is help organize the process and help set a budget. And part of this we call problem seeking. There's a famous book in the design industry called Problem Seeking, and it's one of the foundational tenets of what we try to instill in every project. And that is, if you don't know the problem you're trying to solve, it's hard to create a solution from a design perspective. And so helping administrators figure out exactly how big, where, and why, and then setting a budget, because what can happen over time, and I think Lee was hitting on it as well in his example, we call it scope creep. Basically, everyone has a good idea, but once you define the budget and the scope, you communicate it out and you move forward in that regard. But there are always good ideas that come along the way, and we don't want the budget or the scope to creep up, because the budget will creep up with it as well. So We go to the next slide here. All right. Lee, you want to talk about kind of the organizational process of how you manage projects, and I'll jump in.
Sure. So once again, it's going to largely determine what are your resources and what is the size of your organization. If you are building a new series of exam rooms and you're a private practice, you're probably going to be doing this on your own. You might be the only person, or you and one of your doctors might be the only people managing the project. Compare that to, you're building a replacement hospital for a 500 to 1,000 bed hospital. You're probably going to have representation from every major department, and you're going to have a facilities design and construction department that's going to lead that. And you're probably going to have an assigned project manager using high-level, very complex project management software to track and organize every single aspect of the program. So again, without going into too much detail, I would say make sure that you have a plan. Make sure that you have accountabilities and responsibilities aligned so that if there are problems, we know who to go to solve those problems and who ultimately will be responsible for resolving them and ensuring that they fall in compliance with the budget. It needs to be a very clear, I guess, priority of the organization, no matter whether it's a small or a large project. Anything that involves construction is going to be very expensive. You can't hardly build an exam room for less than $1 million these days. So you're going to be spending enormous amounts of money. Average hospitals are probably running anywhere from 500, well, a small one, probably 200, 250 million, easily up to $1 billion for a large hospital. Greg, what's the price per square foot on average going these days for a hospital?
Oh, probably $800 a square foot, 600 to 800, depending on the market you're in and the size of the hospital. The larger a project is, they tend to be a little bit less in dollar per square foot metrics. The smaller the project, they tend to be a little higher in a dollar per square foot.
Right. And procedural areas always more expensive.
Yes.
A lot more factors go into the design and construction of procedural areas based on the requirements that the safety requirements that those have. So again, we don't have time to go into a lot of those details, but I would say if you can, make sure you have one overall project manager. So you might have a team, but a team without a leader is chaos. So you need to have a designated lead. That could be you if you're in a small organization. It could be somebody from facilities design and construction, or it could be somebody who has done this before, or somebody that just is underutilized and clearly has the bandwidth and the capability of managing this project. Project management as a skill set is something that can be learned. It doesn't have to be something that you've done 100 times before or have a degree in, but definitely take the time to make sure that the person you appoint to be the project manager has the skill set and, importantly, the protected time to manage this project. And if you don't have somebody internally, you need to move to this third bullet, an external project manager or consultant. So it is, in my opinion, it's something of a conflict of interest to have your construction company or your architect serve as your overall project manager or consultant. They're obviously going to provide input to you in areas where they are subject matter experts, but they aren't the ones paying for it. They aren't the ones that are going to have to live with the long-term capabilities put in place by this facility. So it is absolutely in your best interest to have somebody that's representing the interests of the medical group slash hospital facility. And so there are companies out there that you can hire that will come in and do this for a fee. So that's how I've approached the ones that I've been involved with. And I've served in all three of these different environments as either the leader or a team member.
Thank you, Lee. One thing I wanted to point out here too, it kind of overlaps the last slide and this one from a design process perspective. One of the things to always remember is that there's a review process for design, but there then separate from that usually is an approval. And Lee kind of touched on it in a different way, but keep in mind that you're going to have you probably will have multiple people who want and should participate in the reviews of processes and design ideas. But ultimately, it's got to go somewhere else often for a formal approval. Because again, there's going to be a lot of great ideas, but we have to have this process in place and people in place to accommodate that two-step process.
Yeah, that'll be especially important if you are working in a CON or Certificate of Need state. Those are states, if you're not familiar, where a governmental body has to approve the construction of all new healthcare facilities. That's a, we went through a period in the 80s and 90s where there was negligent overbuilding and overbilling for health services. And one of the ways governments got after that was creating review and approval processes owned and operated by the state through the CON process. Texas is not a CON state, but probably half the states in the country are. And some of them are very onerous and some of them are fairly lax. So understanding what those review and approval processes are that Greg alluded to, both outside your organization and inside the organization, are going to be an important part of your learning curve as you start on the project.
Yeah, and good point, Lee. And in that same spirit, hospitals and healthcare in general tend to be very complex design projects, and they include a lot of codes, not only the local code for making sure the building will stand up to wind and rain and things like that, but each state has their Department of Health, which reviews projects, and in some circumstances, they go to other places. So finding a project manager wherever possible that has some healthcare understanding and knowledge is really important in this regard, because it is different than trying to design and build, an office building, for example. Some of the fundamentals are the same if you think about budget and scope and schedule. But there's another layer there of codes and understanding who you need to go to for what kind of reviews and approvals.
Yeah, and different types of clinic settings also have very different requirements. For instance, mental and behavioral health environments have drastically different construction requirements for the safety of the patient than a procedural area or an ambulatory care area.
Yep, exactly. Okay. Oh, yes. Okay, here we go. All right, Lee, you want to kick this off and then I'll jump in on a few of them?
Absolutely. So as they say, the only thing that never changes in healthcare is that it's always changing. So what we used to build hospitals 50 years ago is totally different than 30, than 10, than what we're looking at into the future. So we're going to go over a handful of things that are currently being evidenced as design trends in healthcare that you don't need to be subject matter experts on these. You just need to know that you should have representation in your construction and design team that's looking at these and taking them into effect as you design your requirements. Because it's no longer, I think hopefully by now in your education and or work, you are experienced enough to have seen that we are moving away from an encapsulated delivery of healthcare within the four walls of the hospital, and we only care about how we can control the patient when they are inside our hospital, and we don't care about anything else. We now think of patient care as a much more holistic design. We're looking at a 360-degree approach. How do we integrate with home health care? How do we take care of the patient more effectively before they even get into the hospital? And how do we take care of them better after they have been discharged from the hospital? So part of that is technology, part of that is workflow, part of that is communication, and all aspects of those processes and ancillary services can affect how you design your hospital. And just like houses, it's no longer just, pine studs and sheetrock. It's now kind of technology surrounded by a case. So half of our hospitals are now technology built into the hospital. And we kind of talk about built in versus bolt on. And so you need to be thinking through what are things that are likely to hit, again, what is going to be the design lifespan of this facility? Is it a 10-year facility, a 20-year, a 30-year facility? Within that facility, within that lifespan, what is the obsolescence of certain equipment? And you need to think through, what do we build into the facility versus what do we bolt onto the facility? We don't want to build in things that have an obsolescence every couple of years. You don't want to have to rip walls out every time something gets superseded by a new system. I'm frequently amused and frustrated by the number of clinics I go in that have 20 and 30-year-old intercom systems still in the walls. We have call light systems in our patient rooms that become significant safety problems because we can't easily augment or replace them when they become obsolete and we can't get parts for them anymore. One example I can give is, we are now, and y'all probably know nothing but EMRs, but before EMRs, we had these things called paper charts. And paper charts seems fairly innocuous. You think of something that's, about this wide and you can grab and take with you anywhere. But in a large, complex healthcare system like Baylor Scott and White, we had the entire basement of the hospital, probably 50,000 square feet, that was all the medical records department. And every department and every clinic needed the patient's medical record in time for the patient to be seen. So they built a train, and this train looked something like a subway. And it literally went from the basement of the building through the walls up into the ceilings. It was a gear-based system with hard plastic cases attached to electric train propulsion units. And these, they clamped onto the propulsion unit, and they would crawl through the ceilings and through the walls from clinic to clinic and hospital area as required. And that system eventually 30 years later could no longer be supported. And we had to, one of the factors involved in building a replacement hospital was that we were forced to move because we could no longer get our medical records effectively from the medical records department to the clinics. So that's just one example of how equipment obsolescence can impact your facility and your facility design. So I'll turn it over to Greg for some of these specific topics.
Yeah, thank you, Lee. That your charting comment reminds me of really thinking about the operational modeling on this list. I'm going to jump around a few of them, but the second to the bottom is operational modeling. And what that means for a designer is, for many years, we had paper charts, and they usually sat, as we know, at a nurse station. It was more of a centralized model for the typical patient unit. When we've transitioned to more electronic EMR systems, that largely freed up the ability for the clinical staff to treat patients in a variety of settings. And so that decentralized approach and opportunity that technology allowed had a huge influence on how we designed hospitals, because it suddenly meant if needed, the clinical staff did not all necessarily have to sit at the nurse station and all share one paper copy. So what you began to see over the last few decades is that decentralization of computers at the bedside in patient rooms, computers in the corridors, workstations in the corridors with little sort of niches, if you will. So that operational modeling is really something to think about as you look at the design of units. And part of this for me is fascinating. I think it was actually Winston Churchill who said, in the beginning, we shape our buildings, and after that, they shape us. So I think a lot about that when we design and operational modeling, because the last thing we want is for the facility or the building to limit or inhibit the best possible clinical care that it can have, right? So that's an
Greg, just
example.
a
Yeah.
perfect example of how we address that at a
Yeah.
large replacement hospital. We actually took a shelled area that was not being used, and we had the design and construction team build actual full-scale operating rooms and patient rooms for the clinical teams to come in and do mock exams and mock procedures in to test all of the workflows that you're alluding to, the complexity of those and how the facility itself can shape or limit how the team can work. Critically important in procedural areas, but just as much patient flow especially in more complex areas like ICUs.
Mm, very
It was
good. Yeah.
deemed so important that every doctor was required to go visit the space and sign in and approve, sign that they had approved it. And when they couldn't get enough physicians to go to this 5 mile away building, they actually tore all the stuff down and moved it onto the main clinic campus and rebuilt it there so that the doctors could get in and actually spend more time in that space. Proved invaluable for long-term physician and clinical team adaptation and support of the building design.
Mm-hmm. Excellent. Yep. Doing mock-ups. We're doing some virtual mock-ups, as you would appreciate. We draw in 3 dimensions now. There's other kinds of headsets and so forth. That kind of goes into the technology piece. One quick example that I'm going to combine evidence-based design and hospital-acquired infections on this list, because I know we're running a little short on time, but I have a real project now where we have windows in exam rooms in an emergency department. They're up high over the patient head, and it's beautiful. It lets in natural light because evidence-based design tells us that access to nature and daylight actually can and does have a positive impact on patient recovery. And there's a lot of data behind that, but the hospital-acquired infections, the infection control folks at the hospital said, we don't like the windowsill up there. It's very high. How do we clean it? That's an infection problem. So we had to work through a variety of competing ideas, both solid in their research and the science behind them, and come to help drive a decision for that large institution. So those are some real-world examples. All right. All right, Lee, I think they're kind of the last couple of slides about major lessons learned in our careers.
Yeah, so I've kind of alluded to a couple of them. One of those is don't do anything that's going to get you fired or thrown in jail. when you start messing, especially if you are working in a public environment, and so many of our hospitals are publicly funded, that the probability is that you'll be working in some environment where there's a lot of oversight of how these projects are funded and completed. So don't do anything that's going to get you in trouble. And if you think there might be a problem, air the problem early so that you can get team input, and you might even want to get legal input on what is the right way to go after something. Most large facilities have in-house legal counsel, and so if you are ever unsure, ask early and make sure that you get outside legal opinion or financial opinions to, I'm not going to say it's a CYA, it's the right thing to do. We talked earlier about budgeting. You need to make sure that it's clear from every aspect what budget is covering what. Greg and I were talking early on how frequently facilities are scoped around a budget, and then they forgot to include all of the equipment for the hospital. On average, equipping a hospital is going to cost you 40 to 50% of the construction cost on top of the construction cost. So, a $100 million hospital is actually a $150 million hospital by the time you put beds and OR equipment and new cath labs in them. And if it's a heavy procedural area, those numbers can quickly go up to 60%. Cath lab equipment, you can easily spend, $10 million on the C-arms and the radiology equipment for the cath lab. Just one example. So it's very important to be precise. And as I said early, make sure that you have leadership support and alignment so that when there are problems, and there will be problems, the senior leader is well informed and educated so that he or she can give you a well-informed answer that everybody can be aligned around. I think those are major lessons learned. And then, especially if you're younger in your career, admitting to everybody what you don't know. If you're put in charge of one of these projects, nobody should expect you to be a subject matter expert on this. So it is completely appropriate to say, I don't know about this. Where can we get some outside expertise to avoid us making a very costly mistake because we make a decision without true subject matter input? So those would be my big takeaways.
Thank you, Lee. I think, so from my perspective, a couple of things that I've learned the hard way, and we touched on one of them earlier, and that is setting clear expectations with the administration on a project about who has input and review authority and who has final review authority. Because as an architect, as a designer, I'm taught to listen and to hopefully take in a lot of different viewpoints and somehow create an integrated solution, right, that ends up as a building. But oftentimes, if we don't have a clear roadmap with administration, with their project managers about who actually has input versus approvals, that can be a major problem. Also, budget. Lee mentioned that. We have a responsibility together to hit a budget for you as a design team. Your design and construction team are bound by contracts that if you said, I have $100 million to build this building, we are responsible for drawing and then building something to meet that $100 million. And obviously we want to come in hopefully a little bit under that, but not too much under that, because then we haven't been good stewards of your money for, using all of it. So, and then lastly, like Lee just said, one of the mistakes I made early in my career, and I've seen it in the industry, is confusing project cost with construction cost. Project cost includes everything that Lee mentioned. It's basically the overall cost of a project. We oftentimes throw around numbers and they get confused or conflated. But project cost is construction plus design fees plus furniture plus equipment plus everything else you can think of that goes into. Nowadays, IT, telecom is a large portion of a budget. Construction, like Lee said, tends to be, depending on the project, 50 to 60% of the total cost. So that's another mistake that I've seen and I've made in my career. So keep that in mind as you look towards a project. And I believe that's all the sort of written information Lee and I had for today. Dr. Mitchell, you want to jump in and see if we have any Q&A type
Sure.
activity?
Thank you so much, both of you, for your contributions here. There were a few questions that folks submitted when they registered for the webinar, and I've combined a few of them. So, the first question from our audience is, with the rise of outpatient care, virtual services, and emerging technologies, how are these trends shaping the way we design and use healthcare spaces today? And what do you see as coming next?
From my standpoint, I would say, the main area where we have struggled is trying to fit those needs or those requirements that you just listed within financial means. And so we do that by, once upon a time, we might have built several facilities that were unique niche facilities for each special group to meet their needs. We now are thinking more holistically about a single space that has multi-purpose rooms that could be dual purpose. There are certain areas, of course, that can never change, but for instance, the ORs used to be a cardiac OR versus a orthopedic OR versus general OR, and now those spaces tend to be more uniform, more standardized, with mobile equipment like mobile C-arms that can be moved back and forth between rooms to meet specific specialist needs. We are also we're basically reusing facility designs. Greg, you can plug your ears. You probably don't want to hear this, but we built a hospital and that worked so well after a couple of years that the next two hospitals we needed to build in other cities, we took those exact same plans and we essentially reused them in the new city. Of course, we did the entire process. We sat down with all the doctors, all the team members, because they needed to have buy-in, and we tweaked those designs where necessary for their unique areas. But frequently, I mean, you go to a Chick-fil-A, every single one is exactly the same. It's kind of that model, and tweaked for the ground that it had to be built on, and so that's what we did. But we are changing relative to the amount of space that we design for in-person spaces versus virtual. We are building more spaces, for instance, that include purpose-built monitoring rooms, where maybe we used to have a monitor in every single room. Now we have a central monitoring room with one nurse monitoring all of the patients in the entire floor. And they've literally got floor to ceiling monitors with all of those rooms, and areas that previously would have been a procedural or an exam room in the facility are now being done virtually. For instance, we are built let me say this correctly. We are building for a purpose exam rooms that can also serve as a virtual exam room where the doctor, in between physical visits of a patient, can turn around and see 2 or 3 telemedicine visits from the same exam room.
Yeah. Just to add on to that, what I see and hear in that largely from my perspective is flexibility. We design spaces that are multi-use. Even if our clients don't always ask us to, we're going to do our best to build in from a space use perspective, like Lee was just saying. For example, a med-surg patient room that could become a universal care room, that could become an ICU room. If you get that framework right, then that gives ultimate flexibility over time. The other part is more technology oriented, definitely seeing that grow. We're building in little highways all over the hospitals in the ceilings to accommodate not only the latest fiber and so forth, but other things that we don't even foresee right now, so that the future can be more easily adapted for whatever that clinical need looks like. So
And more easily accessed, so you don't have to
yeah,
rip the wall out to change from copper to fiber or whatever comes after fiber.
right.
The other thing is, if you can't afford it and you don't need it today, shell it in instead of building it out. So every major construction project I've been involved with, we want to build for future capacity, but that's future capacity. It's not today capacity, and it's not today required need. So you don't want to spend money for a need in 5 years. So build the exterior walls, the floors and the ceilings, and leave the entire rest of the area vacant. That's called a shelled space, and that's very common.
All right, everyone. Well, thank you so much. Thank you so much, Greg and Lee, for a very insightful, very thought-provoking conversation today. I think today's discussion really did shed light on an area that's often overlooked in healthcare leadership, design thinking, and shaping better outcomes for patients, providers, and the whole organization. It's really something that healthcare administrators and healthcare administration education really doesn't traditionally think about within education and within practice as well. That facility design is actually strategic. It's not just something that's technical or something to farm out to a consultant. Improving clinical workflows for supporting staff, driving operational efficiency, design decisions carry long-term impacts that I believe healthcare administration education would be well served to incorporate. So to everyone who joined us, thank you again. I'm certainly going to respect everyone's time, and we did say 1 o'clock to head out. So for everyone who joined us, thank you so much for being here and listening and participating to this important and emerging space. You will receive a follow-up email with the webinar recording and any additional resources that will be provided from the speakers. We do encourage you to keep the momentum going, and to that very statement, please do be on the lookout for the next of these alumni-based webinars. This is the first one that we're participating in today, so hopefully we are planning to have another one next semester. So thank you everyone who joined us, and with that, we'll go ahead and sign off. Thank you so much.